Okay, everybody, we're back. This is part 2 of medications and the nursing care that's associated with it. It is just a PowerPoint lecture. So I left you off with talking about hypertensive medications. We're now going to look at medications that are called cardiotonics. And they are basically a cardiac classified glycoside. What does that mean, you say? Well, basically, these are medications that are going to increase the heart rate. They're going to increase the force of contraction, so make the heart squeeze stronger. But it also has the effect of slowing the heart rate. So this medication would be given to somebody who has a heart rate that's going very fast, and it doesn't have a good squeeze, a good muscle squeeze of the myocardium. It's used to treat congestive heart failure and atrial fibrillation. Most of these people, when they get on these medications, such as digitalis glycosides, they usually are on them for the majority of their life, unless they've had some specialized cardiac intervention. Nurses must take an apical pulse for 1 full minute and count the heart rate. You have to listen to every beat. Lub-dub is counted as 1 beat. You hold the medication, meaning you don't give the medication if you listen and the heart rate is less than 60 beats per minute. So if the heart rate is 59 beats per minute, you do not give it. If it's 60 beats per minute, that is considered acceptable. You can give the cardiac medication to the patient. Next slide. Example of this medication, again, is digoxin. And also you're going to see the manufacturer trade name, which would be Lanoxin. And the patient, when they start this first, is usually giving a large dose of this medication. When they're trying to get, remember, that peak level of medication into the bloodstream to make it work and to get this medication on board. And that is called digitalization. And that's always usually done in a hospital or under the prescription and monitoring of a nurse, like at home with a VNA coming to the house. But basically, they give a higher dose of the medicine by mouth, or it could be IV in a consecutive amount of time, and then they bring it down to the normal dose that they want to give it. There is a narrow margin of safety with digoxin or Lanoxin. So we really have to monitor the patient. They monitor them by listening to their heart rate and also by looking at blood work. Early side effects that we may have with this person with the medication is fatigue, very fatigue, nausea and vomiting, anorexia, they just have no appetite anymore, diarrhea, bradycardia, which is a slow heart rate, less than 60, and sometimes some confusion, and sometimes some people report vision changes in their colors, usually yellow and green. Sometimes they get mixed up. The late side effects that people may have with digoxin or Lanoxin, again, is a serious arrhythmia, a serious irregular heart rate, or a slowing of the heart rate. They can have seizures, and they can have behavioral changes. They can be forgetful. They can be sometimes belligerent. So when we have toxic levels of this medication, they will take a serum digoxin blood work and look for overdose. And if we have too much of this medicine build up in the bloodstream, you can understand that the action of this medicine is to slow the heart rate down. So it's going to slow it way down, maybe in the 50s or even in the 40s. So we do have an antidote. And the antidote that we can give them is digoxin. The antidote is digoxin immune fab, otherwise known as Dingibind. That's the short trade name, Dingibind. And so when we've had medicine that we've been given too long, too high, it's greater than 10 milligrams per ml, we want to make sure that we would give this medication the antidote. The medication, if we don't, change its blood level and bring it down, it can be very life-threatening, and it can cause arrhythmias and cardiac arrest. So a normal digoxin level is 0.5 to 2.0 nanograms per milliliter. You don't have to remember that, but I do want you to understand that we do monitor people's levels when they take digoxin, and there is an antidote for it, and it's called Digoxin Immune Fab, otherwise known as Digibind. Cardiotonics are also for cardiac glycosides. Patient teaching is very important. The nurses need to take the pulse, and usually it's the apical pulse. We need to assess them for weight loss and for edema. We also have to assess them for activity intolerance and shortness of breath. They get really fatigued easily as a side effect. We want to assess this medication very frequently in the elderly because they can easily become toxic, and infants. Those are the two ones that are at risk for having cardiac glycoside toxicity. So we also would monitor serum electrolytes because they can become hypokalemia. Laxatives is a common drug that we like to give in long-term care facilities, and you may be administering them. So there are different forms of laxatives, and the one thing you all want to know and get from this, the main point, is that they do promote elimination and defecation of stool when somebody is constipated. There's 4 different types. There's a bulk forming laxative, which is called psyllium seed, which you might know as Metamucil. The second category is a surfactant type of laxative. It's a stool softener, and you might know them as docusate sodium, which is a little red football that helps them have a bowel movement. The third kind is a saline cathartic, which is milk of magnesia, and that's pretty strong. And then the last one is an irritant laxative or an irritant cathartic, and bisacodyl. That is a medication that we can give, and that's usually given as a suppository to help them have an elimination. Side effects, again, we need to understand that there's a huge problem with overuse of the use of laxatives to assist with BMs. It seems that as people get older, less active, less fluid intake, or less fiber in their diet, they tend to get constipated, so they use these laxatives routinely. And that is a problem. It does interfere, these medicines do interfere with nutrition absorption, and they can have a sounding effect also on things like fluid and electrolyte imbalance, because if we take them a lot, you're going to have a lot of bowel movements, but in association with that is a lot of water coming out when they have a BM, and so we could be losing some of their electrolytes. We also have decreased muscle tone with people who overuse laxatives, meaning that the intestinal wall gets boggy and the intestinal wall gets weak, and the intestinal wall requires more and more of the stimulation of this medicine in order to have peristalsis. So it does have a long-lasting effect if we overuse them. And they also may increase the risk for falls in elderly because, they may have stress that they have to get right into the bathroom, and again, might have an accidents with mobility and falling into the bathroom. They are prescribed for constipation and also associated with narcotic use. So very commonly, if we have somebody who has severe pain or somebody who has post-operative pain, we give them a narcotic, and also we may order a laxative. So again, they're used with surgery and immobility. The thing here you need to realize and tell people that they should be short-term use. We should not have anybody on these strong laxatives for the rest of their life. Stool softeners are prescribed to decrease straining, especially associated with cardiac surgeries. And also we want to monitor for serum electrolyte imbalance. And also the nurse needs to look for the consistency of the stool, because one thing is that we need to monitor when somebody has a bowel movement, if it's formed stool, if it's non-formed stool, is it liquid and diarrhea? Is there a lot of water also associated with the elimination process? So we need to look at people's bowel movements in nursing homes. Don't just flush them. You need to look at them and also look for the color. The next slide we're going to just kind of talk about is blood lipoproteins. So we're looking first at people who have atherosclerosis. This is the accumulation of fatty deposits on the inner walls of the arteries and the arterioles. So if we have all this fat supplies, it makes the lumen of the blood vessels smaller. It reduces blood supply to the vital organs, can result in a stroke, can result in a myocardial infarction. That is a heart attack. The term hyperlipidemia is an abnormal level of cholesterol and blood triglycerides in the serum blood. So hyperlipidemia is associated with, it can be with genetic tendencies. So if your parents had hyperlipidemia, you might have inherited that. It also is associated with lifestyle choices, meaning somebody who doesn't exercise, somebody who's a couch potato. It also can be associated with certain drugs that may be prescribed or that they use, and other disease processes also can cause hyperlipidemia. Contributing factors: diet high in saturated fats, a diet high in cholesterol, carbohydrates, alcohol, sedentary lifestyle can all contribute to hyperlipidemia. So this slide here is looking at blood lipoproteins. And the purpose of this is for you to kind of look at what the normal values ranges are. So a cholesterol, we want it to be less than 200 milligrams per deciliter. And they're at risk if they're higher than 200. So 200 to 230 is considered a high cholesterol, possibly developing into hyperlipidemia. We have the high density lipoproteins, that's the HDLs, and we want them to be greater than 60 milligrams per deciliter. If they're less than 35, then that is risk also for developing hyperlipidemia. The LDLs, which is the low density lipoproteins, we want them less than 100 milligrams per deciliter. At risk if you're higher than 130. And we also can check the triglyceride levels. And that's a quick blood test that looks at an overall picture of the lipid proteins, the triglycerides. And again, if it's less than 150 milligrams per deciliter, that's where should be a desirable measure. And if it's greater than 150, again, that's something that the prescriber or the doctor will talk to you about and maybe prescribe medications. So we know that the HDL is the good lipoprotein. It transports cholesterol to the liver for metabolism. We also know that low levels of the high density lipid proteins increase the risk of chronic heart disease, and high levels of the LDLs increased atherosclerosis. So we want to look at, promoting a good level of the HDLs, and again, looking at the low levels of LDLs. We want to make sure that the LDLs are not too high. So with all of that being discussed, we have a medication for people who have hyperlipidemia. And this is the term antilipetics, also known as statins. And what are they? So the HMG-CoA reductase enzyme inhibitor. It's an enzyme. So basically it's an enzyme that reduces cholesterol and the reduction of the LDLs. So that's what we want, reducing the LDLs from the blood. It also will reduce the triglycerides. So the focus here is on reducing LDLs with the use of statins. So we talked about having certain endings that we may look at it, and it's called the suffix. The statin is the term we might be looking at. For example, lovastatin, okay, is a medication that's going to be an anti-limpectic. It's going to lower your blood cholesterol, but it's also known as the trade name as Mevacor. Atrovastatin is also known as Lipitor, and simvastatin is also known as Zocor. So you can see how the statins is right there in the generic name. And again, that the names of the manufacturers are producing quick, snappy names, Lipitor, Zocor. Side effects of taking a statin can be anorexia, nausea and vomiting, constipation, muscle and joint pain, photosensitivity, abdominal cramps, and heartburn. Now, the one thing I do want you to know, folks, for an exam or for any type of test you might see with a statin, is that supposedly these medications have the best action when they're working in the evening. And that is because we want to have this medication taken when the majority of the food in the day is consumed. All right. The other thing we have to teach our patients is avoid grapefruit juice because it inhibits the metabolism of the statin medication. Again, lifestyle modification is important before the drug is prescribed. Usually, again, the doctor will say, you know what, your blood triglycerides are of concern, and I'm going to give you 6 months for exercise and diet. See if you can lose weight, see if you can change your diet before we start the statin. They do usually give you a trial time. Once somebody is on them, they're going to monitor their liver function tests, and we're going to look at their medications because we know that some statins can interact with other medications. So please know that these drugs, the statins, should not be given with grapefruit juice, usually are taken in the evening. Anti-ulcer drugs. They're very commonly used, and we'll see them in many forms, but it's for gastric ulcers and duodenal ulcers. And we're looking at things that we can do to help protect the GI system. So we have the first one here on this slide is antacids. And basically this is considered an alkaline type of medication, and it neutralizes the acid. We also have a histamine receptor agonist. Sorry about that interruption. So the antacids, the alkaline antacids, will neutralize the acid in the stomach. That would be the hydrochloric acid in the stomach. The second one is a histamine receptor agonist. This inhibits the production of hydrochloric acid by blocking the histamine. And this might be known to you as the medicine called Zantac. And the other type of medication that we have for the healing and the decreasing of ulcers is the proton pump inhibitors. They inhibit gastric enzymes being produced from the parietal cells of the stomach. And you might know this drug as Prilosec or Nexium. Okay, so this one's a little different. If you look at all of these, the first one, the antacid alkalines, are something that, we're going to take. It's probably going to be a Mylanta or something like that. The second one, the histamine receptor agonist, is going to be a pill, Zantac, but that's really, it's a histamine that's working on the cell wall within the stomach. And the proton pump inhibitor inhibits the gastric enzyme being produced from the parietal cells of the stomach wall. This one here is, we're looking at antacids and some variations to them. So antacids generally neutralize gastric acid. So if you think about classes that you learn in chemistry, your pH, you're going to bring that pH from the acid level more to a neutral level or to a base level. All antacids are not the same, folks. Please read a little bit about them. Some of these antacids are aluminum base, some are magnesium oxide base, some are calcium carbonate base, sodium bicarbonate base, and simethicone base. And so the thing I want you to understand about antacids is that if somebody has renal failure, if they're having kidney problems, you have to be very careful about what you give them as an antacid. And sometimes physicians forget this. They can't remember every patient. So you might say to them, Mrs. Jones has had some renal issues in her kidneys, and before you prescribe the antacid, maybe you need to kind of look at that. So my question here, or my focus on this slide is, do not use a magnesium-based antacid if they have renal failure, because they cannot excrete the magnesium ions. An example of that is Mylanta. See, Mylanta, that is a magnesium-based antacid, and if somebody has renal failure, they should not have that medication at all. It will promote further kidney damage. So our nursing considerations, again, we want to make sure that when we're looking at antacids, something's happening within their stomach. They're being upset. Why is that? You might have to do a little bit more research, finding out what's going on. Maybe it's the foods that we're giving them. Maybe it's a new medication that's irritating their stomach. Or something else could be going on with them physiologically. So the recommendation with antacids is they really don't use them more than 2 weeks. If you're using them constantly all the time for 2 weeks, the prescriber needs to be aware of that. If they're on a low sodium diet, the best type of antacid to choose for them is Riopan or a Mylanta product, because it has low sodium base in it. We all know that antacids can promote constipation. So that's something you want to monitor, how often they have, they go to the bathroom and have a bowel movement. We also want to monitor kidney function for any type of toxicity that can happen to the kidneys with taking a lot of antacids. And again, some medications will interact with an antacid, so review your administration of medication. Look them up if you're seeing that some of these medicines may say don't give with an antacid or close within time. So it's really important that we kind of, had a little talk about what these medicines do, what some of your nursing responsibilities are. The Faculty of Nursing decided that these were some medications that we should address as freshmen before we go to the long-term care facilities, because more than likely you will be giving something for pain relief. You will be giving something to lower their blood pressure. You may be giving something to lower their cholesterol. You may be giving them a diuretic. You may be giving them an antacid or something to help promote stool elimination. So these are the general things that we want to look at. So when you're reviewing for a test or reviewing these medications, please remember that you want to make sure that you're assessing the patient. You're looking at what their signs and symptoms are. You know the action of the drug, and you know what the nursing responsibilities are for assessment and care. So again, if we have somebody who has blood pressure medicine, antihypertensive medicine, we're going to do some teaching about safety and about orthostatics. We're going to monitor them for electrolyte imbalances, and we're going to make sure we take their vital signs. If you're giving digoxin, you know as a nurse, you're going to assess their heart rate for a full minute before you give it. But you're also going to assess them with digoxin to see if they have any side effects, because we know that this medication, this digoxin, can really have a serious effect on lowering the heart rate of the person. So you want to make sure that you're kind of monitoring that. So in essence, this was a review of medications. There will be questions from an exam on this. And we'll also be discussing this in our discussion session when we meet. There will be a guest professor coming in to address this lecture, and she will be providing a case study so that we can discuss in our conference time. All right, I hope this has helped you out, everybody. See you soon.